afternoon, and thank you so much. As you can tell, I am not Albert Pons. I am his PhD student. And before even starting, I want to say thank you all for coming all here today, and also congratulations on the amazing talks that were before me. And also thank you to the CERCARE team. I must say, it is pretty exciting for me as a PhD student to be surrounded by brilliant researchers I really admire and look up to. I must say I have thoroughly read your papers. So I am Clemente García, radiology trainee from Murcia, Spain, and PhD student at the Translational Imaging Biomarkers group from the Bellvitge University Hospital in Barcelona. And today I'm going to show you our results on evaluating CERCARE perfusion maps performance on the 4 major brain tumors discrimination, but also I want to emphasize on the stress test that we performed evaluating them between different acquisition parameters. So I think you are all aware that discriminating between the 4 major brain tumor types is a pretty hard task because they are really heterogeneous, both clinical and from a biological perspective, but also in the neuroradiological appearance, and this can indeed streamline different therapeutical decisions. So in this heterogeneous context, DSC Perfusion has given us deeper insights into the tumor biology, but as my PhD supervisor, Professor Pons, brilliantly pointed out last year, DSC perfusion, the main issue is that it's super sensitive to the acquisition parameters. So this has historically limited its generalizability and the reproducibility. And also, we have been talking today about thresholds and cutoffs. But these thresholds and cutoffs are linked to the acquisition parameters that you are performing in your centers. So establishing universal thresholds has been a pretty hard challenge. So we have also been discussing today the value of CBB in discriminating between these tumor types, and CBB is indeed the most extensively researched perfusion metric in the literature, and more specifically in the most challenging task, which is distinguishing between glioblastoma and metastasis. But I must say that the thresholds are not only heterogeneous, but most of the times are indeed overlapping. So here I'm going to show you 2 of our patients who had indeed the same CBB values. So we must say there are 2 main paradigms in the DSC perfusion context, which are, let's say, leakage-optimized protocols which don't use pre-bolus, and CBB-optimized protocols which use pre-bolus and intermediate values of flip angle. So this is one of the main issues of establishing a generalization between centers. There are centers that are mainly focusing on optimizing leakage, hence suboptimal for cerebral blood volume, and on the other hand, there are centers that are optimizing cerebral blood volume and hence suboptimal for leakage metrics, apart from other technical parameters that do indeed influence DSC perfusion metrics. So in this study, what we wanted to evaluate, as I have said before, was not only the performance of CERCARE perfusion maps, but how do they behave between different acquisition parameters, and if it is possible to establish thresholds that work for both paradigms, those using leakage-optimized sequences, those using CBB-optimized sequences, and maybe for a more broader heterogeneous setting, let's say you use both, or another situation that is uncommon among neuroradiologists, but not so uncommon in radiology departments, not even knowing which protocol you are using. So we assembled a cohort of 212 patients between 2023 and 2025, 101 glioblastomas, 52 metastases, 46 meningiomas, and 13 lymphomas. And we performed a dual acquisition protocol. Let me introduce you our dual acquisition protocol. It consists on a sequence without pre-bolus and a high flip angle, which represents the first paradigm I have said, the leakage-optimized sequences. And then we perform a second acquisition using the first bolus as pre-bolus. So it is in a dual acquisition, the leakage-optimized and the CBB-optimized sequence. So by performing these 2 sequences sequentially, we could, in theory, optimize the information we are obtaining through DSC perfusion. So we perform an automatic supervised tumoral segmentation of both the enhancing component at the T2 flare peritumoral abnormality, I must say manually corrected by us, co-registered to the DSC space, and then extracted all the CMRO perfusion maps normalized to the normal appearing white matter. To our understanding, I'm aware you all know CMRO perfusion maps, but to our understanding, they represent 3 different biological spheres. OF and CMRO represent metabolism. On the other hand, CTH, COV, and TTD represent microvascularization. And the classical perfusion metrics that we could estimate before the vascular model represent gross vascularization or macrovascularization. So our first task was seeing the performance of a single pairwise comparison. So here you can see the 6 possible combinations, and I'm just going to show you some of them pretty briefly. For glioblastoma and lymphoma, you can see that COV showed a diagnostic accuracy as the area under the curve of 0.92 in the first protocol. For glioblastoma and metastasis, indeed, the hardest challenge in the neuroradiological literature, it reached a diagnostic accuracy of 0.79 in the peritumoral T2 flare abnormality, let's say edema. I'm going to say later that, as the previous speaker said pretty nicely, it's not edema, it is a more complex thing, but let's say, for academic purposes, edema. And for meningioma versus lymphoma, you can see we reached a diagnostic accuracy through CMRO₂ of 0.86. So given this amazing and outstanding diagnostic performance, we asked ourselves, could it be possible to obtain thresholds with a nice performance that is independent of the acquisition protocol? As I said, for those using a non-preloaded sequence, for those using a preloaded sequence, or for those who don't even know what they are using. So here you can see how well they perform, or let's say how well they behave between the 2 acquisitions, and a Bland-Altman analysis confirmed that they do not change between acquisition protocols, except for TTD. So if they did not change between acquisitions, we should be able to have this, let's say, universal or cross-protocol thresholds. So we did this experiment, a synthetic stress test lab-generated heterogeneous setting. If we have 212 patients with a dual acquisition, we could consider them instead of 1 patient with 2 acquisitions, 2 patients with 1 acquisition. So we perform a cross-validation in which we randomly shuffled how many patients had the first acquisition and how many patients had the second acquisition. So we were simulating a multi-center study or a center which had multiple scanners with multiple protocols, and we recalculated the thresholds and their performance. And here you can say that they perform exactly as good as in the sequence 1 and in the sequence 2. This is a global summary of sequence 1 and sequence 2 thresholds and performances. I want to show you not only how well they perform, but how they are almost the same. And here's the gold, how well they perform in this heterogeneous setting experiment. So this also led us to think that maybe building classificatory models in which we combine these 3 biological spheres would give us more performance, or maybe a deeper insight into the biology of these tumors and what the CMRO perfusion metrics mean. So we built binary trivariate logistic regressions models that were both for the non-preloaded sequence, for the preloaded sequence, by combining metrics from both sequences, and in the particular case of glioblastoma and metastasis, combining enhancing component, edema, enhancing, and edema. So here you can see the performance of the first acquisition models. They perform outstanding, but I must also say the significance is not always positive for the single value, single metric approach, because if it was already super good, it is hard to perform even better. However, this is giving us some deeper insight into the biology tumor because of the relationship between the metrics. I will show you later what I want to say with this. Here, for the sequence 2 models, you can see they also behave exactly the same, super nice performance. And for the cross-sequence models, again, with the 3 biological spheres. And we wanted to try a validation of our results in another cohort, so we assembled a historical cohort that was done in our center before this experiment, and also this validation is of really high quality because it has a lot of acquisition settings that are also known to affect the DSC perfusion performance, such as baseline points, flip angle, repetition time, echo time. So this was a really complex validation that wanted to stress test our results. And I must say, they worked perfectly fine. This validation was only tried in the cross-sequence or universal thresholds and also in the first sequence, non-preloaded sequence, because in our center we were doing a non-preloaded sequence before this experiment. And as I have said before, building classificatory models with the 3 biological spheres is interesting not because of the performance, but because of the relationship between the metrics when evaluating between tumors. So what I want to show you here is the key perfusion signature of brain tumors. We have seen a super intricate and interesting relationship between the tumors. Please do not take literal this photo because this is a semi-quantitative radar plot. This doesn't want to establish thresholds. This just want to show the relationship. But between glioblastoma and metastasis, we have coined a term which is the vasculometabolic discoupling. Glioblastomas are indeed highly vascularized tumors. However, this vasculature is highly disorganized with arteriovenous shunting, so erythrocytes do flow super fast, and glioblastoma cells do not have enough time to extract the oxygen. So high CVV values with low OEF. On the other hand, metastases do have also high vasculature, but this vasculature is organized, resembling the primary tumor. So metastasis cells do indeed have time to extract the oxygen. So high CVV and high OEF. On the other hand, brain lymphomas are hypercellular tumors, but as you know, aberrant lymphocytes have a limited oxygen activity, so lower OEF when compared with glioblastoma and metastasis. So we have seen not only how well CERCARE perfusion metrics perform across different acquisition parameters, but we have gained a deeper insight into the biology of these tumors. So now that we know that they perform super good in non-preloaded sequences, preloaded sequences, and heterogeneous context, now we are really able to give cutoffs or thresholds tailored to which sequence you are using in your hospital, whether it is non-preloaded, preloaded, or whether you don't know what you are doing. So just to finish my presentation, CERCARE perfusion metrics offer an excellent diagnostic performance. They are reproducible, robust, and this allows us to establish cross-setting thresholds, and this will in the near future allow us to deploy in all institutions. And just to finish, I want to give my deepest thanks to my team, of course, to all of you for being here today, and more specifically to CERCARE, not only for the invitation, but also because I really think that we are really changing the care we are delivering to our patients with the vascular model. So thank you so much.
Thank you so much for this beautiful presentation, and I think you addressed a lot of the questions we've had also about how do combinations of values provide signatures of tumor characteristics. Are there questions from the audience? So what would the next step be? Let's say that you wanted to take this knowledge and give it to people who have different scanners, do not necessarily sort of have this understanding of, which parameters do what. What's the next step for you? Do you have a little algorithm that will be blue or yellow or whatever, depending on which tumor it is?
Okay, so as you've seen, we are talking about pairwise tumor task comparison. However, in the neuroradiological practice, you don't always have just a differential diagnosis of two tumors. So maybe the next step might be classificatory models, let's say forests, decision trees, and also we have plenty of ideas like how well do these metrics or these three biological spheres behave in the follow-up of treated gliomas. Could we perform a clustering in glioblastoma and see if they have different biological profiles because of this vasculometabolic uncoupling? There are plenty of questions that I'm pretty excited to see. Yeah.
Excellent. Thank you so much. And
there was a question.
Oh, there is a question. Excellent. Thank you.
Yeah, thank you for a great talk. This is more of a comment, perhaps, than a question, but I do want to point out that there are other acquisition schemes, for instance, dual echo or multi-echo acquisitions, where you can quantify both the susceptibility effect and the T1 leakage effect at the same time. And there aren't really any downsides to doing this, so I would hope in the future that this might be something that Circare will support. Maybe you already do, I don't know. But so then you can get rid of preloading, and you can use a high flip angle, and you've got all the information. So it's just a comment, really, rather than a question.
Do you want to comment on that?
I'm aware about those acquisitions. Matter of fact, we are collaborating right now with the creator of synthetic dual echo acquisitions, which is Dr. Zambito from California. And also I must say that there might be a fourth biological sphere, which is indeed leakage. And when we are talking about leakage optimized versus non-leakage optimized, I think it is a more complex phenomena in which we are looking not only at the leaky blood-brain barrier, but also at the vascular architecture and cytoarchitecture of these tumors and how they allow the gadolinium to extravasate. So I'm pretty excited to see, but it might be something much more complex than T1 and T2 effects.
Maybe I should say that I'm not part of Circare, but I was approached by someone in the break who talked about an exciting project with, T1 and 2 weighted interleaved, and from a kinetic point of view, it's wonderful, and the sequences there advanced a lot. So I think there's really a lot to be gained there. So I will try to convince them. I'm sure they already are. Thank you so much for a wonderful talk. I think future radiology is in good hands in many places. Thanks for a wonderful talk.